Hello, everyone. Welcome back. I hope you're all doing super well. My name is Karan, and today we're going to be talking about multiple sclerosis.
So multiple sclerosis or MS is a complex autoimmune condition. And as the name suggests, it's autoimmune. So what is it attacking exactly? It causes demyelination within the CNS. Now, we'll talk about the specifics of what's going on. But before that, I think it's important to know that it's more common in Caucasians and women. So the prevalence of MS in women is about 10 in 10,000, while that in males is about 2 in 10,000, is a five times greater risk of having MS, you could say that. It's a chronic condition which most commonly follows a relapsing remitting course. So let's talk about what's going on here. So with the demyelination, so there's obviously your white matter and your gray matter, right, in your nervous system. You also know that the myelin sheaths that are present covering the axon help with nerve conduction. These myelin sheaths in the CNS are supported by oligodendrocytes, and it's important to know that the myelin sheath and the oligodendrocytes are what are specifically being attacked. And it's also important to know that this is limited exclusively to the central nervous system, so not to the peripheral one. What's going on? So if you attack the myelin sheath, you would be causing axonal injury and inflammation. And both of those together prevent those good conductions throughout the axon, which obviously the myelin sheath is meant to help with. How does that happen? So let's say you have your acute inflammatory stage. This is where either you've had your first presentation or you've relapsed. Because this is autoimmune mediated, you commonly have CD4 and CD8 T cells that are mediating this entire response. What's special about these cells compared to many other immune cells is that they can actually permeate or cross the blood-brain barrier. Now, the blood-brain barrier is in place to prevent any abnormal cells or bacteria from invading it. It's a nice sterile environment, and your neutrophils, your macrophages, all of those cannot normally permeate the blood-brain barrier. But what's going on here is you have your CD8 and CD4 cells that can cross them normally. They do cross the barrier and they cause inflammation because they start attacking the axons, the myelin in the axons and the oligodendrocytes. Now, once you have this inflammation, you know that inflammation leads to dilation of microvessels, right? And once you dilate these microvessels that form the blood-brain barrier, you increase the gaps between those cells. And by increasing the gaps, you are allowing in many other inflammatory cells and mediators to slip through. So now you have your neutrophils, your macrophages, a whole bunch of cytokines that are just flooding in. And it's unique because these cells otherwise would not have been able to make it through. The combination of the dilated vessels, the inflammation at the level of the axons, as well as the oligodendrocytes, all are going to basically cause your CNS to go into a bit of a state of shock and cause the acute neurological symptoms that we see. And we'll talk about what these symptoms are in a bit. Here, I have something called perivascular cuffing. Now, perivascular cuffing is basically what I described when I talked about the infiltration of these cells. As you can see, these are your vessels, and surrounding these are all inflammatory mediators that normally should not be there. But because of those increased spaces, your neutrophils, macrophages, and other inflammatory cells have been able to invade into the blood-brain barrier, and they surround, obviously, the vessels, which is why it's called perivascular cuffing. And that's a common microscopic change seen on pathology. In terms of clinical presentations, you can have constitutional symptoms like fatigue and headaches, which, as you can imagine, it would be common for someone undergoing such a widespread inflammatory response. A few specific ones that are important to talk about. Firstly, optic neuritis. This is one of the most common and earliest symptoms that they note. What's basically happening is that you damage the cranial nerves as they're coming out, particularly your optic nerve. By doing so, you can have issues with vision and color. Specifically, you lose your sensitivity to the color red. What you also get is a relative afferent pupillary defect called Marcus Gunn pupil. For those who know what a Marcus or what RAPD is, great. If you don't, I'll quickly explain it because I think it's important when it comes to actually understanding what we're doing. So a relative afferent pupillary defect. When we do our cranial nerve examination on the eyes, one of the tests we do is the RAPD swinging test. So first, let's say you shine a light in the left eye, okay? You're shining light in the left eye, the optic nerve, the retina that's receiving the light is going to transmit that signal through the optic nerve. The optic nerve then goes to your brain and tells both the eyes that, look, this is very bright, let's constrict the pupil. And both pupils constrict. So even though you're shining light in just the left eye, you will have pupillary constriction in both the left and the right. Same thing goes with the right. So if I'm shining light in the right, you should have constriction in both the right and the left. What happens with the RAPD is that once you shine the light in the left eye, you're normally meant to quickly switch it over to the right eye. And if both the sensors or both the optic nerves are functioning normally, the right eye should just stay constricted, right? Does that make sense? Because again, you should again have constriction in both the right and the left eye, and that should not be particularly different. What happens with a relative afferent pupillary defect is when you have damage to the optic nerve of one of them, you have kind of a chaotic picture. So what is going on there? Let's say a person has an issue with the optic nerve on the right side. That basically means that when you flash the light in the right eye, it's not going to be detecting that light as well. A typical presentation of a Marcus gun pupil is going to be you shine the light in the left eye. Again, this is, let's say, the issue is on the right side. Shine the light in the left eye, both pupils constrict, and then you switch it on to the right eye. And as you're shining the light in the right eye, you notice that the pupil dilates a bit. And that to you should be very weird because something has gone horribly wrong. Pupils should not dilate relatively. So the reason it's called a relative afferent pupillary defect is because the pupil is dilating relative to what it was earlier. I hope I haven't confused you with that. Additionally, you can have demyelination of the various spinal cord tracts. So you have your DCML responsible for fine touch and proprioception. So you would lose that as well as have numbness. The spinal thalamic is responsible for pain and temperature. So you can have neuropathic pain. And then the corticospinal tract, which are your upper motor neuron lesions, would present with spasticity, hyperreflexia, and a positive Babinski sign. And these are all your typical upper motor neuron lesions. You can also have your cerebellar signs, which are your Danish, so dysdiadokinesia, ataxia, nystagmus, intention tremor, and so on. You can then also have cranial nerve signs, as I talked about earlier. So optic neuritis is one of them. You can also have diplopia if your ocular nerves and ocular muscles aren't functioning as well as the facial nerve palsy. Lastly, you can also have autonomic dysfunction. So issues with your bowel, bladder, partial hypertension, sexual inhibition, and so forth. So as you can see, it's kind of weird, wonky neurological signs all over the place. And that is typically how they would present. Neurological signs that otherwise don't fit in with a single lesion. So what investigations do we do? A plain MRI of the brain and spine is going to be the investigation of choice because, again, it's CNS lesions, right? And you would often see multiple sclerotic plaques. And it's important to know the most common sites where these plaques are found. They can be the periventricular, so next to the lateral ventricles, infratentorial or cerebellar, or juxtacorticals next to the corticospinal motor tracts in the spine. You can also do a test called a contrast MRI with gadolinium. And what that tells you is episodes of acute flare-up. So acute episodes or relapses often show up as bright hyperintensities on a gadolinium contrast MRI. In terms of a CSF examination, because it's a predominantly lymphocytic response with your T cells, you might have lymphocytic pleocytosis and oligoclonal bands. Here you can see are your lateral ventricles, and these white hyperintensities are the plaques. So here you can see some periventricular plaques. These are some infratentorial plaques seen in the cerebellum. And as you can see here, this is a juxtacortical plaque. In terms of a diagnosis, you need to know the McDonald criteria. So the McDonald criteria basically states that in order to make a diagnosis of MS, you can't just go off a single lesion or a single sign. You need to have two criteria. You need to have disseminated CNS lesions that are separated by space and time. You need both of them. So what this means is you need lesions that have appeared at different points in time, which can be either seen in terms of clinical manifestations with new symptoms or imaging changes. So let's say you do a gadolinium scan, you see both acute flare-up hyperintensities as well as hypointensities that might indicate a past kind of inflammatory picture or a past plaque. They also have to be disseminated in space. So you have to have lesions present at two or more sites. This can be seen on imaging. So if you see both periventricular lesions and juxtacortical lesions, that's good enough. Or clinically, if they present with very different neurological signs. So let's say if a person presents with optic neuritis and also has these burning pain sensation down their leg, that is obviously two different lesions, right? And that is enough to make a diagnosis. In terms of treatment, like most autoimmune therapies, we go down a very similar path. For episodes of acute flare-up, we want to hit them with high-dose glucocorticosteroid therapy, and this usually lasts for about a week. And your go-to with steroids is never stop them abruptly. So you are going to start off with a gradual taper. What you can also do additionally is something called plasma electrophoresis. And this is often done when it's really severe and it's not responding well to other therapies in the acute setting. Long-term, you can use immunomodulators like azathioprine and methotrexate to reduce the risk of more acute attacks. And then we have these new class of medications called biologics, which are your monoclonal therapies. And they are namely, I will not try to pronounce them because I will butcher them, but these two. The last thing that's important to know is very commonly you'll have patients ask you, well, doctor, I've had this flare up. Is it going to get better? Is it going to get worse? Like, what's the prognosis like? And it's important for you to know the four basic or your four broad types. The first one is your fulminant MS. This is the worst one to have, where you have the first episode and it just gets worse and worse and worse and doesn't really get better. It happens in less than 10% of cases. You then have primary progressive, which is similar to fulminant in terms of it doesn't really have major episodes of remission, but it's a bit slower. So it starts off and then just keeps slowly getting worse. You then have relapsing remitting MS, which is by far the most common type, where you might have acute flare-ups and then go back into remission and stay in remission for a while and then suddenly get worse. So it's a kind of an up and down pattern. And then lastly is secondary progressive, where you start off with a relapsing remitting course, and then for some reason you just stop going into remission. So it's kind of a primary progressive, but it started off as relapsing remitting. And here is kind of a graphic to just show that. And that's going to be the most common one. That's your primary progressive, your secondary progressive. We don't really talk about time progressive relapsing, but these three are important to know, plus your fulminant MS. I hope that helped. If you guys have any questions, please feel free to get in touch. Always happy to answer them. And as always, please look after yourself and please look after your loved ones.